Uh, Good afternoon, everybody. Welcome to Grand Rounds. Today, it is my pleasure to introduce co-presenters, Alicia Mercado and Ann Rudruck. They both work with the Iowa Department of Public Health in the Bureau of HIV, STI, and Hepatitis, and they have very kindly accepted our invitation today to provide us with a review of an unfortunately increasingly prevalent problem, and that is syphilis. So please join me in welcoming Alicia and Ann. Thanks.
Hello, everyone. My name is Alicia, and I am a regional health equity specialist. So I have been in this position for 1 year. Before this, I was a medical case manager for people living with HIV in Black Hawk County. And then I've been in social services, domestic violence, sexual assault for my work history before that. But I'm very happy to be here today with my coworker, colleague, Annie, and we hope we give you the information that you're looking for, and please feel free to ask questions.
Can I introduce myself?
Oh, yes, sorry. I was going to do later.
Hi, everyone. My name's Annie Rudruck. I'm a disease intervention specialist. I cover 14 counties in the state, one of them being Story County. I've been a DIS for a little over 2 years, and I did work in the Bureau of HIV, STI, and Hepatitis before that. So I follow up on all reportable STDs and HIV cases in those 14 counties.
So today, I'll start with the objectives. We're going to talk about the statewide increases in syphilis, describe syphilis signs, symptoms, and stages, describe screening and treatment recommendations, serological testing for syphilis and interpretation of the results, and then discuss partner management and patient follow-up. Our agenda, as you can see here, is many of the things I just stated. So I won't go through those again. And at the end, if we have some time, we do have some case studies prepared. So our statewide syphilis data, here are highlights from 2022. Of the 877 cases reported, 626 were early infectious stages. Of these 626 early infectious cases, 66% of the cases were among men. And then majority were men who have sex with men. As you can see, the MSM initials there, that's what that means. The 2022 data you see here is final data for 2022 calendar year. All stages of syphilis, meaning primary, secondary, early non-primary, non-secondary, and unknown duration or late. We'll go into the stages of syphilis later in this presentation. You can see we started to see an increase prior to COVID-19 pandemic in 2019, and then case counts continue to increase from there. For infectious syphilis, this means transmittable to someone else. It includes primary, secondary, early, non-primary, non-secondary, formally early latent, symptoms not present upon exam, but the patient had signs and symptoms in the past year. Here we see early infectious syphilis and syphilis all stages side by side for the last 10 years. The navy line representing early infectious cases and the gold line representing all stages of syphilis from 2012 to 2022. And as you can see, there's been an upward trend. Here you see the breakdown in case counts and percentages for males and females for all stages of syphilis in 2022. This is a shift compared to 2019 when we saw about 90% of the cases among men and 10% of the cases among women. Speculations are that more women are getting tested. There's active heterosexual transmission, more men having sex with men and women, and then different epidemics in different parts of the state are also happening. For example, in Woodbury County, northwest Iowa, Sioux City area, we're seeing more heterosexual transmissions, whereas in Polk County, central Iowa, Des Moines area, we're seeing more transmission among men who have sex with men. This slide represents race and ethnicity breakdown for all stages of syphilis in 2022. I want to draw your attention to a few racial groups that are disproportionately impacted. Black or African American population represented about 18% of stages of syphilis in 2022, but it only represented 4% of the population of Iowa, according to the most recent census data, and showing a disproportionately impacted population. Same with American Indian or Alaska Native population. This racial group represented about 7% of cases in 2022, but represented less than 1% of the population in Iowa. The Hispanic population represented about 15% of the cases in 2022, but only represented 7% of the population in Iowa. The reason for this has to do with social determinants of health factors. If you're interested in more specific information around social determinant of health, I can return and do a more robust presentation about that. Our next one gives you an age breakdown for cases of all stages of syphilis in 2022. Congenital syphilis cases are not figured into this. We will go over that next. They have their own category in their own case definitions. We don't see syphilis cases concentrated in any particular age group. This is different between chlamydia and gonorrhea, where we do see very clearly defined age group concentrations. For example, the 15 to 24 year age range. Something to note, notice the case counts for ages 45 to 54. That is this column right here. Compared to the 20 to 24 age group right here. This is why it's important to screen and why sexual health assessments are important at any age. So this is talking about congenital syphilis. The 11 cases we had in 2021 were more than the state had seen in the last 20 years combined. There are a number of reasons this could happen. I had more notes on that and don't see them here. But you can see here in 2022 that the data shows there were 8 cases in 2022. The gold color that you see on the bars represents the number of cases that met the case definition to be deemed a true case. As you can see, the years before 2021, we had, as low as 1 case, 2 or 3, and then in 2021, we jumped to 11, and then 8. So there was a huge jump in the numbers. The navy coloring on the bars represent cases that did not go on to meet the case definition. There are cases that were averted due to intervention. On the public health side, we use surveillance case definitions, a set of uniform criteria used to define a disease for public health surveillance. Surveillance case definitions allow public health officials to classify and count cases consistently across reporting jurisdictions. Surveillance case definitions are not intended to be used by healthcare providers for making a clinical diagnosis or determining how to meet an individual patient's health needs. Do you want to add anything to this?
No, I think I'll just go into the next section about syphilis, signs, symptoms, and stages. I will say it's very clear from the data that syphilis is increasing, and as someone who works syphilis cases, I don't think that I've gone 1 week this year without receiving an early case. And I get a lot out of Story County. So part of what I do is speak with the healthcare provider, help them determine what stage it is, what treatment is needed. So I guess just a quick syphilis overview. The black and white image is what the syphilis bacteria would look like under an electron microscope. This image is from the CDC Public Health Image Library. It is from 1972. In the color photo, you can see the more clearly defined corkscrew spiral shape. The organism burrows into the moist mucous membranes of the mouth or genitals. And just a little syphilis fun fact. Syphilis is a very old disease dating back to 1494 in the 15th century in Italy during the War of Naples. That was the first documented case and outbreak. The disease was much more severe then, Sir William Osler, who is considered the father of modern medicine and one of the founding professors of Johns Hopkins Hospital, stated, "He knows who syphilis knows medicine." He described syphilis as the great imitator, as it looked like so many other things, which is still something that we hear today. There's a lot of patients that may present with a syphilis rash, but they are sent to dermatology or they're treated with topical steroids. That is something that I encounter a lot. So syphilis stages. These are the stages of syphilis that we'll go through. Primary, secondary, early non-primary, non-secondary. That was formerly called early latent, and then unknown duration or late. And that was formerly late latent. Those names have been updated. And then there are additional manifestations that may be neurological, ocular, and otic. I will say that any of these manifestations can occur at any stage. I have encountered, patients diagnosed with secondary who are losing their vision. So, and something I've heard from some providers is that, those symptoms cannot develop if it's secondary. It can, and I think that is a really common misconception. So, primary stage of syphilis, the most common symptom and the one that is kind of hard to detect sometimes is a painless sore called a chancre. This can be located any place that you can have sex. It usually lasts 1 to 5 weeks, and the tricky thing is that it will heal without treatment. This is the most infectious stage. Another thing that is tricky about chancres is that because they are typically painless, patients may not know that they have them. I've talked to a lot of patients who think it's an ingrown hair or think that it's like a cut in their mouth or something like that. And if you don't know you have it and then you're having unprotected sex, that's a really easy way to spread the infection. So the classic presentation is a single painless ulcer or chancre at the site of infection. However, it can present with multiple painful lesions, and a lot of times I see that confused with HPV or like a co-infection or outbreak. So that can be difficult to distinguish. So this is some photos from the CDC. Of course, these are like the scariest photos. They always show you the most serious ones. Like I said, there can be one chancre. Sometimes there's multiple. And a lot of times, since it doesn't hurt typically, people may not know that they have it, and it might be inside of their body. It might be external. They just might not know. So the secondary stage of syphilis, the most common symptom that we see is a rash. And in the classic presentation, the rash is on the palms of the hands and the bottom of the feet, but it can present elsewhere. So I have had a patient with a full body rash, very clearly a syphilis rash. He saw dermatology first. He took steroids, topical steroids, and it just turned out to be secondary syphilis. And again, this symptom will go away without treatment, which is what makes it so tricky. I've had patients say they thought it was like poison ivy or like they have allergies or like using a new soap because it goes away. The infection is still infectious during this stage. So these are, again, some more pictures of rashes. I actually recently just had a patient send me a picture of their rash, and it's very clearly a syphilis rash, but it was very close to her skin tone. So if she was just looking at it, she would not know. And the only reason she knew it was syphilis is because she was like, "Hey, I have a rash." And I was like, "Can I see it?" Saw it, and it is secondary syphilis. So again, this can be anywhere on the body. Most commonly, it is the hands and the feet. And this is the most noticeable symptom of secondary syphilis. This is typically when I see people getting diagnosed, like in an ER or like after they've been to another healthcare provider. Then the next stage is syphilis early, non-primary, non-secondary. So this is someone who may present in a stage of syphilis that may not have any signs or symptoms upon assessment. They may recall a symptom like a rash 3 months ago, 6 months ago, but it's since gone away. Or maybe we have a negative syphilis lab within the past 12 months. They have no signs or symptoms, but now they have a positive lab. So there's a few different things that I use to determine if someone is early non-primary, non-secondary. Again, a lot of patients who present at this stage have no recollection of signs or symptoms, but I may have a negative lab that's within the past year, or like a partner who names them and they are both infectious. So again, if someone presented with no signs or symptoms, but we don't have any labs, whether they be negative or positive within the past 12 months, then they would be unknown duration or late. So in this stage, this is where we believe that the infection occurred more than 12 months previous to their test, or there is insufficient evidence to conclude that the infection is more recent. So there's really typically no symptoms, or people don't know. It can be really tricky to diagnose, or, if they don't recall and there's no other criteria that they meet, we have to stage them as unknown duration or late. Some long-term complications. So some of these can take years to develop, and someone may have no idea that they have had syphilis, but the damage is being done. And what I talk to patients a lot about is that once the damage is done, it's not really reversible. Like, treatment is still important, but if there's been damage that's done, it's done. Sometimes people could be infected for 15, 20 years and just have no idea, and then present with some of these more serious symptoms. Next, Alicia is going to go over the sexual health assessments and why it is important to do it with every patient that you see.
I found my syphilis notes. Okay, so here is a slide that can give you a quick glance at some of the important questions to ask when you're doing a sexual health assessment. Think of the 5 Ps. Ask somebody about their partners, the number of partners they've had, their gender, the timing, so if it's been in the last 2 months or versus the last year, concurrency, so if that partner had sex with another partner while still in the sexual relationship with the client. Practices, and so what types of sex are they having? Vaginal sex, anal sex, oral sex, sharing sex toys, and ask an open-ended question like, is there anything else I should know about your sexual health to help provide you with the best care possible? Talk about protection from STIs, STDs. Do they use condoms? Any other types of barriers? With whom and in what situations do they use protection? Have they had any difficulties with condoms or accessing their types of prevention that they want? Any reasons why they don't use condoms? What about pregnancy? What are their plans around pregnancy? Pregnancy history, current or prior contraceptives, future contraceptive needs and wishes, any difficulties with contraceptives, stuff like that. And then the last P is past STI history. So have they done testing in the past? Have they had any diagnosis? And the same questions for any partners that they've had. I can also do a much longer, more broad informational session about sexual health assessments if you would like in the future. Do we go over congenital syphilis again?
Yeah.
In the future? Okay,
do.
I thought we did. There you
So next we're going to go over some screening recommendations for syphilis. So the question is, who should we test? I'm not going to go through all of these because it's quite a bit, but I do want to draw your attention first to pregnant women. There is a new recommendation that pregnant women are screened again. So typically they're screened during their first OB appointment, screened again in the 3rd trimester. We just put out a recommendation from Iowa HHS about that. That's something that, some providers do, some providers don't, but we are seeing an increase in individuals who acquire syphilis during their pregnancy. And as you saw in the data, we are seeing an increase in congenital syphilis. So doing another syphilis test is an easy way to possibly provide an intervention in that. So we're now seeing about 25% of our syphilis cases in women and about 75% among men who have sex with men. Just a few years ago, about 90% of our cases were among MSM and 10% were among women. So we're seeing a shift in that. And as we saw earlier, again, an increase in congenital syphilis. So next, I am going to go over the syphilis testing and treatment algorithm. So syphilis is typically a blood test, but occasionally we do see swabs of chancres that can be taken, but a majority of the time we'll see a blood test. So we have the traditional and reverse algorithm. I believe Mary Greeley uses the traditional. So first there is a non-treponemal test that is done. And I believe Mary Greeley does RPRs. So if that comes back non-reactive, then as you can see in the algorithm, there's no additional testing done. However, if that comes back as reactive, then we want to run a treponemal test. So this is the confirmatory test. One thing that I run into a lot, and this is like statewide, all the clinics I work with, is ordering standalone RPRs that come back reactive and no confirmatory test. So in my process, I get that RPR test, and I have to follow up with the clinic, and I'm just like, hey, is there a treponemal test that's ordered? Part of my job is to make sure that this sequence is complete. And that can be really confusing. There's a lot of different names. There's a lot of different tests that can be run. Then we have the reverse sequence, which is becoming more common. That is where you do the treponemal test first. And then if that is reactive, it reflexes to an RPR or a VDRL. Both of them are used, but neither one of them can be used by itself to determine a stage of an infection or really what's going on. The whole algorithm does need to be run. So again, non-treponemal test, that would be the RPR or the VDRL. And then we want to make sure that we are requesting a titer on all reactive specimens. Titers are very important. They are used to monitor where the infection is at, especially after treatment, and if there is possibly a reinfection. Then, of course, we have the treponemal test. This one is typically reactive for life, so that can be really confusing for patients. I talk to patients a lot about that because they keep thinking that they have syphilis or they've been treated. So we talk a lot through that and that may be reactive for the rest of their life, regardless of treatment. So yeah, this is the reverse sequence. The treponemal test is ordered first, and as of June 2022, the state hygienic lab did begin using the reverse syphilis testing algorithm instead of the traditional. And this is the one that our bureau would recommend using, but that varies widely from facility to facility and even provider to provider. There's the algorithm again. And we will have this available when, I guess, the presentation is sent out. I do have a handout that can be sent out that has this. I always send this to providers to use as a reference. I still use it as a reference. I think it's very helpful just to see what tests you may still need and what to ask your lab for. So next we're going to go over syphilis treatment recommendations. So I say to every patient who I speak with that tests positive for syphilis, it is easily treated and cured. We just need to be doing the testing. Patient history is very important to determine staging and treatment. On the CDC's website, there is a wall chart, a pocket guide, a full treatment guide that's available. There's also a mobile app from the CDC. It does have the most recent treatment recommendations in it. So, if you're working in a clinic or in the ER and you just need to double check something, there are resources available. So this is the other side of the syphilis staging and treatment algorithm. So as you can see, the question is, were there symptoms at the time of blood draw? Yes. Was there a chancre? The RPR or titer VDRL may be positive or negative, but the confirmatory test is reactive or non-reactive. That may be primary syphilis, and the treatment for that would be bicillin, 2.4 million units IM in a single dose. It is the same treatment for secondary syphilis. It is the bicillin, 2.4 million units IM in a single dose. And at the time of testing, there may be that rash that is there. The RPR is usually positive, and then the confirmatory test is reactive. If there are no symptoms at the time of the blood draw, this is where we're trying to determine if it's early non-primary, non-secondary, or unknown duration or late. So this is where patient history is really important. I want to know if they've been tested before. If they have, I want to know how long ago it was. Do they have any partners that have been diagnosed with syphilis in the past 12 months? If they've previously been treated for syphilis, has there been a 4-fold increase in their titer? The RPR and VDRL can also be positive or negative, but the confirmatory test is reactive. Early non-primary, non-secondary, it is still the same treatment as primary and secondary. But if we do not know the duration of someone's syphilis infection, it would be the 2.4 million units IM, 3 doses spaced 1 week apart. That can be really difficult to get patients to return to the clinic for, or if a provider has treated a patient when they were in clinic and then, we talk and we're like, no, they need 3. It can be a little difficult sometimes to get them back. And if they do miss a dose, they have to start over. For neurosyphilis, congenital syphilis, ocular syphilis, there are different treatments. It's usually an IV penicillin that's 10 to 14 days. So there is a treatment alternative for primary, secondary, or early non-primary, non-secondary syphilis. The alternative is doxycycline, 100 milligrams, twice a day for 14 days. We really do not recommend that. That's really difficult for patients to adhere to. And then if it's unknown duration or late, doxycycline, 100 milligrams, twice a day for 28 days. So that's a lot of doxy. I know I would have a hard time, keeping up with that. So we really try to avoid that if possible. This might be later in there, but I do want to say too, for pregnant patients, there is no alternative treatment. So it is the bicillin, 2.4 million units. It still depends on the stage that they're at. If the pregnant individual needs the 3 doses, they can go no more than 9 days in between those 3 weeks. So that recently changed. It used to be 7 days. We have a little bit more room now. And if a pregnant person does have an allergy, they need to see an allergist, go through desensitization, and then still receive the penicillin. And that must be completed 30 days prior to delivery. So next we're going to go over follow-up testing and partner management. So this is like a small titer guide. And we recommend rechecking the titers. I say 3 months, 6 months, and then a year. What I'm looking for is a decrease in that titer after treatment. If there is no decrease, that's a conversation with the provider and maybe do they need more treatment? Is it a reinfection? Did they have sex with their partner before they both were treated? What's going on? So we're looking for decreases and then, of course, increases for a possible reinfection. And patients who also are living with HIV, we do recommend that they're tested at 3, 6, 9, 12, 24 months after the completion of treatment. However, I know a lot of providers that work with patients living with HIV test at every visit. I think that ID here does that, so, being tested regularly. This is our STI reporting form. So in the state of Iowa, the lab is required to report and the provider is supposed to report. That gets a little iffy sometimes. So if you're getting a phone call from us, it's probably because we haven't received this form. But really, I'm just looking for treatment information, possible signs or symptoms, the information that I need to help make a recommendation. This form is used for chlamydia, gonorrhea, and syphilis. However, even though you do need to use this for syphilis, you may still be getting a call from us. Usually I need more information. And if someone needs 3 doses of the bicillin, I'm still going to have to call and verify that the patient did receive that. So you may have a lot of interaction with the DIS is what I'm saying. Treating sex partners is very important to prevent further transmission of the infection, also to prevent the index patient from becoming reinfected. We always recommend that all sex partners of persons diagnosed with primary, secondary, or early non-primary, non-secondary are presumptively treated regardless of their results. There can be that incubation period of up to 3 months after an infection has occurred. So for anyone that is a contact to early syphilis, we always recommend presumptive treatment. So in summary, be vigilant for signs and symptoms and test accordingly. Screen all sexually active individuals. Treat presumptively when indicated. And please reach out to us. I am here as a resource as a DIS. You're probably going to hear from me anyways. So if you have a question, I'm more than happy to help provide guidance. And if I don't know the answer, I will find the answer. So I just want to say thank you for having us here. I believe we have some time for questions. Thank you. This is our contact info. Are there any questions in the room?
Yeah, the numbers for the increase in Iowa, was that
Nationally, there are increases, so Iowa's not unique in that. I don't, I actually just looked at this morning during a meeting. So for gonorrhea, chlamydia, we typically see a younger population, like 19 to 24. But for syphilis, we see a little bit older. That is like the next age group up. We are starting to see a little bit of a younger population, but I would say it's more like middle-aged individuals that are testing positive.
Thank you. And I would like to point out that they do have business cards back here on the table that you can take with you. If you have any questions, you can reach out to them. If you might think of something later today or tomorrow. So those are here as well. Stop by and grab one.
Since we do have a little bit of time, I do have a few case studies. I believe we still have a few more minutes. So there's just a few of them, but I would like to go through them. So case study number 1. It's a 35-year-old cisgender male. They present with a rash on their palms and soles of his feet. He states that he's never had syphilis before in the past and has never been tested previously. We have no history and no records of his previous testing history. So how do we stage and what treatment would be recommended? Since he's presenting with symptoms, the rash is typical of secondary. We do think that this is acquired recently. Our case study does not say how long he's had the rash. A normal course of the disease would be anywhere from 2 to 6 weeks, average of 4 weeks. We have no previous labs. But because of the symptom presentation, we would stage as secondary and treat with the 1 dose of bicillin. So our second case study, we have a 26-year-old pregnant cisgender female who presents for a regular checkup. She's found to have an RPR of a 1 to 64, has never had syphilis testing in the past, and currently has no symptoms. She states she is allergic to penicillin with a history of rash and shortness of air with previous penicillin treatments. How would you proceed? So we would stage them as unknown duration or late, and then we would refer to allergy for desensitization to treat with the bicillin once a week for 3 weeks. Like I said earlier, pregnant individuals cannot have doxycycline as an alternative treatment. And then in our final case study, we have a 31-year-old cisgender male who presents to an STI clinic with an ulcer on his penis and I can't pronounce that. He states the ulcer is painless, started 3 days ago, and he noticed swollen lymph nodes in his pelvic region. He also has developed ringing in his ears with his hearing loss, which he describes as muffled hearing. What would you do next? So otic manifestations can occur at any stage of syphilis. If the patient has otic manifestations of syphilis, the case should be reported with the appropriate stage of infection as if those otic manifestations were not present. So this would still be diagnosed as primary due to the chancre that recently developed and was present at the time of testing. Like I said, the otic manifestations can occur at any stage, so it is possible to have both. That's it. Thank you.